Hello, my name is Ibrahim Kim. I'm the Executive Director at the Council of Korean Americans. We are so thrilled that you can join us for this webinar and this webinar series where we focus on the COVID-19 pandemic and its impact on our communities. This week, we wanted to bring to you some conversations and stories about how the people that are on the front lines of this war are doing, our medical and public health professionals, as well as bring you stories of how Korean American physicians are making an important contribution toward this fight. Today's discussion will be on the question of vaccines. We will be bringing together two Korean American global medical experts on infectious diseases. First is Dr. Jerome Kim. He is the Director General at the International Vaccine Institute in Seoul, Korea. And secondly, we will have Dr. Annette Sohn, who is the Vice President at the Foundation for AIDS Research, and she's located in Bangkok, Thailand. Together, from their unique positions as well as locations in the world, we'll be talking about not only vaccines and issues related to drug repurposing and other important drug-related questions, but also how this COVID-19 pandemic may be impacting the developing world as well.
My first guest is Dr. Jerome Kim. He's the Director General of the International Vaccine Institute, the world's only global organization devoted exclusively to developing and delivering effective and affordable vaccines to protect the health of the most vulnerable around the world. Among his many international accolades and his long career in the U.S. military, it's interesting to read that Dr. Kim was recently identified as one of the 4 most distinguished leaders pursuing one of the greatest public health challenges of the 21st century, which is the decoding of the human immune system. He is currently living in Seoul, Korea. My second guest is Dr. Annette Sohn, the Director of Treat Asia and Vice President of Global Initiatives for AMFAR, the Foundation for AIDS Research. She is a pediatric infectious disease specialist who has focused her research on HIV and co-infections in the Asia-Pacific region. What I'm most proud of is that she is one of the Council of Korean Americans' international members. And on a personal note, she's my cousin and based in Bangkok, Thailand. Welcome to both of you.
Thank you.
Thank you. Good morning. Dr. Kim, let's start with you. What's your assessment of the COVID-19 pandemic compared to previous episodes of international outbreaks and epidemics such as SARS and MERS or even the swine flu? Are you concerned how this disease is progressing across Asia, Europe, and the US?
Yeah, I think, compared to the other coronavirus infections or epidemics that have occurred so far, this one has been by far the most widespread. It holds the greatest potential for loss of life around the world. And, with SARS, we knew that the rate of transmission was pretty high. The interesting thing or the sad thing about this SARS-CoV-2 or COVID-19 is that it is as infectious as the flu, but its mortality rate is 10 times higher. Rather than, people who are coughing and sick being the transmitters, in this case, there's a significant number of people, maybe 80% who are just mildly symptomatic. And these mildly symptomatic people can transmit as well as the people who are sick. So that we have the potential for, people who appear well, but who in fact are infectious. And that's the way it's spread around the world. It's really been an amazing thing to watch this disease start in Wuhan, up to Korea for the first major out of China outbreak, and then spread globally around the world to Europe, the United States. And and it's often, unfortunately, the case that governments are not prepared to deal with it. And it's even more true in the developing world, where we're beginning to see reports of unexplained outbreaks of deaths or a cluster of cases where they were able to bring tests in that they've identified as COVID, which we think are probably just the tip of the iceberg, the same way the outbreak in Italy started with, an index case who didn't obviously have a source of a relationship to China, and who in fact was probably not case 1 or patient 1 in Italy, but maybe patient 2000, patient 2000 in Italy. So the disease had spread extensively before that time, completely unknown. the government. So I think it has the potential to really be a global pandemic. It probably is going to last more than just a season. And it could kill hundreds of thousands of people in the United States and around the world. We can't even begin to estimate.
How about you, Dr. Sohn? Are you, you're based in Thailand, and are you starting to see the spread in Southeast Asia? And do you agree with Dr. Kim that we are just really seeing the tip of the iceberg in the developing world? Because right now, the cases that have been reported are fairly low relative to the developed world. And why do you think that's the case?
I think we should definitely be concerned about the potential for rapid spread in low and middle income country settings, and particularly in densely populated areas. You asked the question about why we haven't seen so many cases, and Dr. Kim mentioned the lack of testing, which I think is the top reason. But there have been other ideas that have been raised about why there has been sort of a delay in seeing this bump and increase of cases. And some people have said maybe the higher temperature or humidity may have played some role, different cultural practices. But really, it seems like this just may have delayed the epidemic timeline. We are definitely seeing an increase and rapid rise in the number of cases here in Southeast Asia just in the last few weeks in the Philippines, in Indonesia, and here in Thailand. And this is also mirrored in countries like Brazil and South Africa. So I think that we are not testing enough to know what the true denominator of cases are right now. In Indonesia, the current death rate is about 9%, which is extremely high. And I think this has a lot to do with who is getting tested, which are those who are the most symptomatic. And until testing is scaled up, we won't know the full impact of COVID-19 in that country.
A question to both of you. Just in your comments, it sounds like both of you are concerned about how governments are able to respond, particularly in the developing world. Just their capacity to respond is very limited. But in the developed world too, I'm wondering, particularly we here in the United States, there's a lot of debate of how the government has responded and how the various regional governments, our state governors and so forth, are responding. Are there, from your perspective, are you concerned are you concerned about how the United States and Europe is responding to this current situation?
I think one of the things that you notice as you've been looking at these numbers now for 6 weeks or so is that when the infection is first described in a country, the death rate is high. As we expand testing, the death rate seems to drop. So the United States, the death rate was above 7% in the very early stages because we only had, as Annette said, the most severe cases identified and the people who were basically in intensive care and dying of what looked like COVID disease, and we tested them and they were positive. As we testing, that rate drops. And so, in Korea, it was under 1% for a while or near 1%, and it's come back up to 1.5%. In the United States, it's gradually dropped to 1.5%. And that seems to be, between 0.5 and 1.5%, about where people think the mortality rate should be. So, in a lot of these developing countries, I think one of the guesses is that you really are at a state of undertesting, and that you'll pick up more mild cases and you'll have a greater number of survivors when you start more extensive testing. The problem isn't only the kids, though. I mean, in some countries, there isn't the infrastructure available to do the PCR test that's necessary. Often there isn't the machine. So in certain African countries, we're getting pleas for not only kits, which are can be donated by the Jack Ma Foundation, but there isn't the ability to use kits, which is again speaks to under-resourced settings, not having the appropriate set of tools for governments to make correct decisions based on data. And that I think is the key in China and Korea and the other Asian countries. They had the ability to make rational decisions based on data. Have to kind of, in an outbreak, you have to divorce yourself from the emotions and fear and all these other things and really look hard at what information you have available as you make decisions.
And I suppose I would add to that, Abraham, you asked specifically about the US in particular, and I think there seemed to be a lot of people in the public who were surprised or disappointed at the initial response. I think one thing to remember is that there were, according to reports I've seen, 700 job openings at the US CDC because of a federal hiring freeze. And so if we don't invest in the public health systems of our countries, from the primary health clinics to the referral hospitals and to the centers of disease control, wherever they might be, whatever they're called, I don't think we should be so surprised that countries are struggling when they don't have the resources, the centralized resources, to deal with an outbreak of this nature.
Dr. Kim, let's focus specifically on vaccines. Could you share with us, from your perspective, how far are we from an effective vaccine? We read about a lot of the developments that are going on in various parts of the world. But from your opinion, how far are we from?
So, and we do this for vaccines other than COVID vaccines. When people ask us, well, how long does it take and how much will it cost? The figure that we quote, actually, that was discussed and more, even in a Gates Foundation funded article, is it takes 5 to 10 years and $1 billion. And, these are not ordinary circumstances. So governments around the world, regulatory agencies, the WHO, an organization called CEPI, have worked to try to accelerate the process of vaccine development, to develop an efficacious or an effective COVID-19 vaccine in as short a period of time as possible. The best guess is if everything goes right and the vaccine is effective, then in 12 to 18 months, we will have the proof of the vaccine. Once that's done, then you have to get it approved and you have to get it manufactured. So hopefully many of these things will occur in parallel and not sequentially, because that will slow things down. And so, it is possible in 12 to 18 months. It's remarkable that, with CEPI, as soon as there was an announcement of the disease, CEPI put out feelers to multiple organizations to find out if anyone thought that they could develop a vaccine, get into humans within 4 months. And 4 organizations were contracted initially. I think that number is now up to 8 by CEPI. And their task was to get a vaccine tested in humans quickly. And the first company to do that was Moderna, which is a US company. And they started on the 17th of March, injecting into humans, which is amazingly fast for vaccine development. Other companies are expecting to begin vaccinations in April. Again, remarkably fast. Will it? It'll never be fast enough. I mean, as we speak, hundreds of thousands of people have been infected and tens of thousands have died. But for vaccine development to proceed, remember, we are vaccinating healthy people. So the vaccines actually have to really have a high bar set for safety. And so we have to make haste, but we also have to be mindful that we're giving this to people who are healthy and we want them to stay healthy. So there's always a balance, a tension in vaccine development. And, this is no exception. I mean, the problems caused by that pandemic should not be complicated by vaccines which are not perfectly safe in humans. So you have 2 charges, safety and efficacy, I guess 3 if you count speed. And going to be a real effort. Luckily, this organization called CEPI, which is funded by countries around the world, Norway, Sweden, Germany, Japan, India, France, the United Kingdom, but not the United States, really was able to use this funding, which is about $1 billion, to very, very quickly contact and fund organizations that could develop vaccines quickly, get them into humans quickly. That was really key to the early part of this effort. The Chinese government has also funded vaccine development, and the US government has started also, but on their own and not in collaboration with others.
So would you say in general that there is quite a bit of global cooperation? Obviously, you've mentioned that some of these individual countries are doing their own development, but in general, do you feel like there is good collaboration across the globe in terms of trying to get a vaccine out to all these folks who are suffering?
So, and I think, maybe this is a realization that the epidemic will be with us for a long time. Not only these small companies funded by CEPI initially, but now some of the big companies like Johnson & Johnson and Sanofi are making big efforts now to try and develop a vaccine. And that's critical because, small companies, small biotechs can do it very quickly. But when it comes to vaccine manufacture, the big vaccine manufacturers, whether they be in Europe, America, or India or Korea, are capable of turning out tens of millions of doses of vaccine. And if you imagine that everyone in this world should be vaccinated, that's at least 7 billion doses. And if you need more than one dose, the multiple of 7 billion. So it's a huge number. And so we have to succeed, and we have to do it quickly and with an eye to safety.
How about you, Dr. Sohn? Is there any concern from your perspective, given your work in the developing world, on the aspects of this development of vaccines? In terms of, there's a lot of effort going on in the developed world, but there is eventually a question of access and distribution to these areas. From your perspective, are you concerned, or what's your perspective?
I think what Dr. Kim had mentioned about the role of CEPI and this sort of multi-country, multi-government level engagement in trying to develop a vaccine, cost is a major feature. And there are groups that have emphasized the importance of this vaccine being able to get to people where they need it most. And so my concerns are actually not initially on the vaccine, because this is coming from a more nonprofit sector. My concern is actually that we have an influenza vaccine, and many people choose not to get that vaccine. So from a public health perspective, we don't actually know if everyone will be willing to get a coronavirus vaccine. And that's where I think this issue of a very high bar of safety that Dr. Kim mentioned is so critical, because if there are serious side effects with these first vaccines, it could lead to more anti-vaccine sentiment, which I think is a great risk to public health right now globally, not just when it comes to influenza vaccines. So I'm really hoping for a concerted effort with an eye to not making a profit, to make sure the vaccine is accessible to all, and also making sure that people get accurate scientific data about the reliability of the vaccine and side effects associated with the vaccine. Unfortunately, with COVID-19, we've seen a lot of fake news and incorrect information out there. Many groups are spending hours, days, weeks, and so much of their time trying to get the public to look at science and evidence and data that are reliable. And I think that will be something that the public health systems need to do at the same time that the vaccine developers are bringing this vaccine to market.
To both of you, we hear about, when we talk about pandemic, that they sometimes come in waves. They go around the globe, and the possibility of even the virus mutating or various strains. Is there any likelihood in this particular virus of possibly mutating, or perhaps we're working on a vaccine on a particular strain and all of a sudden the virus mutates and the vaccine becomes less effective? Or are there those kinds of risks as well?
Annette?
Or Annette?
I would definitely defer to you. I mean, my understanding is the virus has not substantially mutated to where it would interfere with vaccine development.
Yeah, so far they've sequenced 1,000 strains around the world, so 1,000 out of the 300,000 or so infections. And so far it looks like, out of an entire genome of 30,000 base pairs, maybe 11 point mutations. So it really is looking like it mutates a bit more slowly, maybe tenfold more slowly than influenza. So the likelihood is that even if it takes a year, we probably will have a vaccine that works. There are unanswered questions around vaccine development, unfortunately, but the virus itself has not been mutating very rapidly. We can always be surprised.
Yeah.
Or there could always be a new introduction. If you look at the history of introduction of HIV, there were multiple independent introductions of a jump from monkeys into humans or chimpanzees into humans. And finally one took. We don't know that coronaviruses aren't doing this exact same thing. And this is the one that had the right virological properties to allow it to propagate very efficiently in humans and be spread very efficiently. MERS is not like that at all. The MERS coronavirus doesn't transmit readily from human to human. And that's been our saving, it's been a saving feature in MERS infections. That really, they tend to occur in clusters in the family, a very small cluster, or in hospitals among healthcare patients to healthcare workers. This coronavirus is very different.
I'd like to switch gears a little bit and talk about drug repurposing. Could you talk to us about drug repurposing? There's been a lot of discussion about using medicines that have been used for other purposes, such as HIV or malaria or Ebola, to now maybe using those drug repurposing or off-label, as some have called it, to shorten the timeline to get something out there to combat COVID-19. Let's start with you, Dr. Kim. What's your view on drug repurposing, and is it a promising route?
So I'm primarily a vaccine developer, but I think that a disease where 98% of people get better on their own or with supportive care, you have to be very careful about interpreting data from trials that don't have appropriate controls, because did nothing, which is essentially what we have right now. 98% of people will get better on their own. So then the question becomes, compared to an appropriate control, does the repurposed drug or a new drug decrease the number of people who need to be hospitalized? Does it decrease the number of people who die? Does it decrease the period of time a person needs to be hospitalized? So does the presence of virus in the throat, does the virus disappear from throat swabs or nasal swabs more rapidly in people given the medicine? Or does the medicine prophylactically prevent doctors and nurses from getting sick? Now, all of those would be clear indications for use of a particular repurposed drug or a new drug. And we have to be really careful. People have died taking hydroxychloroquine. I mean, there are side effects to all these drugs, including cardiac side effects. And if you use hydroxychloroquine and azithromycin together, you have two potential similar side effects. So you have to be very careful, and really it's important to understand these things in the context of the disease and whether they're actually doing what we think they're doing.
How about you, Dr. Sohn? Are concerns from your side as well?
I mean, I completely agree with Jerome. I think that clinicians on the front lines are really scrambling to try to find something, anything. And that's what we saw in China during that really rapid period of time when they were so overwhelmed with cases and with very severe patients. But the science, I think, will give us and guide us, give us answers and guide us to what we need to do. We had a clinical trial showing that an antiretroviral medicine for HIV did not show improvement in COVID-19. We've just had another trial, a small number of patients with hydroxychloroquine and azithromycin that may show some improvement in terms of carriage of the virus. But at the same time, there are these side effects. And I think I worry that people go to social media and do online searches and then come up with the idea that they can self-medicate. And some of these drugs in some countries are over the counter. You can get some of these medicines without a prescription. And so in that situation, particularly in low and middle income country settings, I really worry that people will start trying to treat themselves and end up with severe side effects or even dying, as we have seen in the United States. So I would definitely rely upon the experts, the infectious disease experts in the hospitals and the people who are guiding public health policy on a national level to let us know what is appropriate and what is safe.
Just in yesterday's news here in the Washington Post, it looks like the US FDA did approve hydroxychloroquine and chloroquine to be used to treat COVID-19. And I know there's been kind of anecdotal news reporting that some people, like you, that some people took matters into their own hand and took the drugs and it had horrible side effects as well. So do you feel like perhaps, is this, I mean, you've mentioned the side effects and the possible negative outcomes, but are we sending the wrong message around the world, I guess, in terms of as the United States is approving these kinds of repurposed drugs, or what's your sense?
Well, maybe I can comment just on the hydroxychloroquine and azithromycin combination. If you are in a hospital where an infectious disease physician is able to prescribe this medication to you, you can get an electrocardiogram to make sure you don't have an underlying cardiac problem. You can be monitored to make sure that you don't develop a side effect on this medicine. Then, if the physician thinks it's indicated, maybe it can be managed. But if you're giving this out or taking this because you choose to take it, you're not getting evaluated, you're not having your heart examined. I think those are dangerous directions to be going in terms of the public health response. So yes, the FDA approved it, although not everybody in the infectious disease community may agree with that. But it's being used under controlled circumstances in referral level hospitals and COVID treatment centers. It doesn't necessarily mean that that message should translate to a primary healthcare clinic in Thailand. Dr. Kim?
Yeah, no, I agree with you. And, I think that one way or the other, the fact that the FDA has allowed its use almost provides a justification. I mean, the FDA has always emphasized the drugs that it approves are safe and effective for the treatment of conditions. In this case, they approved it without a true indication of its efficacy, which creates problems because now, people will say, well, it's approved indication, it's okay. In fact, the efficacy data are not really solid. And it creates an unfortunate endorsement of the use of this drug. I mean, there are physicians who've taken the drug prophylactically. There's really no evidence that it's effective prophylactically. Maybe it does and maybe it doesn't. Other people report that patients who need hydroxychloroquine can't get it. And again, we have to be very careful when we create, and as a medical scientist, I am reluctant to endorse a product. I mean, even things that look like they have strong in vitro activity on the basis of tests that are not done in humans and are not well controlled, because we've been led astray before. And I think we have to look at this very carefully, and the FDA does too, because its responsibility is safety and efficacy.
So I'd like to conclude our conversation with one final question to both of you. What do you think are the reverberations or the long-term impact on our public health systems and medical research as a result of COVID-19, our experience of these last few months and probably for the next year or so? Do you feel like there will be negative or positive impacts, or what's your sense? How about we start with you, Dr. Sohn?
So for me, the problems that we have experienced with the lack of COVID-19 testing, the personal protective equipment, they've really exposed deep weaknesses in our public health systems in the highest income countries in the world, as well as in the low and middle income countries. And we need to invest more in these systems, again, from the simplest primary healthcare level up to the referral hospital level, from laboratories to ventilators. And I'm really hoping that governments and policymakers do not forget this when we're on the other side of the pandemic. But I suppose the other thing for me is that there will definitely be short and long-term consequences on the care of other health conditions. So people living with HIV are still living with HIV. The same goes for those with diabetes and other chronic care conditions. And if they cannot get the medicines that they need and the care that they need during this time when we're so focused on COVID-19, there may be permanent health consequences for those individuals, as well as the programs that have been developed over decades in order to support them. So those are the kinds of things that I'm worried about in terms of the healthcare impact. And we haven't even touched on the social and economic burden of what we're doing with social distancing. Although it's necessary, there are major consequences on people, many of whom are millions around the world who live in poverty and who rely on daily or monthly wages that they won't see because of this pandemic.
Dr. Kim?
Yeah, so it's really, those are really great points, Annette. And, from a public health perspective, I think the thing it should remind us is that, like everything, and to, I guess, use a phrase from former Secretary of State James Baker, pandemic preparedness prevents poor performance. The United States thought it had a pretty good pandemic preparedness. If you look at the old rankings of countries around the world, the United States was at the top. We had 12,600 ventilators in storage in case of an outbreak. This epidemic has shown that, every pandemic is different. And we should be ready for surprises. We should be ready to reinterpret our assumptions on the basis of information that's presented. I hope that, like Korea did after the MERS outbreak in 2015, the United States will look back at this and help and plan its appropriate courses of action. How do you coordinate at the state and federal level? How can the federal government push things down to the state that will allow states to act effectively in a uniform way against a pandemic that threatens all Americans? It doesn't matter if you live in Wyoming and you think your attack rate is low. In fact, your number of cases, given the population, may be fairly similar to what they're seeing in other parts of the United States. The bottom line is we have to be ready. We have to plan these things. We have to think through them. Korea passed the Infectious Diseases Control Act after the MERS outbreak that allowed the government to do the kind of tracking that it did if a pandemic is declared or if an epidemic is declared. There's an infectious disease emergency. That kind of thing you can't create in the heat of battle. You don't want to. You want to be able to look back at the gaps, the issues, and come up with laws that deal with them rationally, that are thought out in advance and give you the ability to act effectively and decisively in the situation. Even I remember we used to get these alerts on the radio. There's a beep, and then in the event of a real emergency, we will give you the following information. Well, the same system needs to be extended from radio to all the other forms of media that my kids get their information from. And it isn't the television or the radio. And there needs to be a consistent set of messages. Who develops those? Who reinforces them? All of these things need to be determined and planned in advance. I think, unfortunately, our memory is fairly short. So our ability to act on it is going to be limited by how quickly we can put things into place, how quickly the US CDC can coordinate with state and territorial health offices and departments of health to create something that will protect the United States the next time something like this comes by. Maybe people are going to argue this is a once-in-a-century event. Well, if it occurs again during our lifetime, maybe not my lifetime, but in other people's lifetimes, if we're not ready, then really we've let the countless numbers of deaths that occurred already go to waste because we haven't learned to protect ourselves appropriately. The other part is the United States, and again, we go through these periodic episodes of isolation. I think this epidemic tells us that these viruses do not respect borders. And if we can't help with the outbreak in Korea or in Africa, then it's possible that these outbreaks will spill over into the United States. And we've seen the perfect example of it in COVID-19. Again, reinforcing the idea that we don't live in the world ourselves. The oceans don't protect us anymore. In order to have our global economy dependent on imports from all over the world and exports to all these other countries in the world, we have to be ready. Things that are going to strike in Africa or out of China or South Asia. We have to be ready, and we have to be ready to work with other countries quickly and effectively in order to get these things under control.
Well, thank you very much for both of your time and sharing your expertise with us this evening in your time and this morning in my time. We really appreciate the work that you're doing out on the global front lines, and thank you very much for just giving us a little glimpse about the future as well, especially in the vaccine development. So thank you very much, Dr. Sohn and Dr. Kim, and we appreciate your time today.
Thank you.
Thank you.
Thank you again for being a part of this series, as well as we hope that this is an important part of your growing, learning, and awareness building as we all go through this very uncertain and turbulent times of this disease as it spreads across our country and our world. So thank you for your support, and we hope to see you at the next webinar.